Hello, everyone. My name is not Barb Cat, unfortunately. Unfortunately, I wish Barb was here, but I am Paul Weber, and Barb was not able to join us for technological reasons, but I am really, really honored for the opportunity to welcome Jim Ayukekbong uh, to present how can long-term care settings be prepared for the next pandemic. Now, this is part two of a teleclass that he gave in January, where he talked about the situation of pandemic preparedness in long-term care. And we're going to get more into that. Now, Jim holds a doctorate in medical science with a specialization in epidemiology. He is an expert in infection prevention and control, specifically and especially in congregate living settings like long-term care. And he serves as a member of the IPAC Canada Advisory on the IPAC Canada Advisory Board of the Ministry of Long-Term Care. He's also vice president of infection prevention and control for Southbridge Healthcare, which is in Ontario, where he leads and provides strategic oversight for the infection prevention and control program of over 50 long-term care and retirement homes, including 12,000 residents and staff. Jim is an adjunct lecturer at Dalai Lama School of Public Health and the Queen's University School of Public Health, both in Canada. And he's chair of the Professional Advisory Committee of Humber College Infection Prevention and Control Certificate Programs. Now, Jim is a global health expert. He's supported One Health initiatives and has led international outbreak response efforts for diseases such as cholera and yellow fever and Mpox and Ebola. He is a really nice guy, and he's a really good soccer player. So I'd like to introduce Jim to present how can long-term settings be prepared for the next pandemic. Jim, over to you.
Thank you so much, Paul. Like you mentioned, this is part two of our initial conversation. We started earlier this year, and the question was, is long-term care prepared for the next pandemic? During that part one presentation, the answer was no. And today, we are here to discuss how can long-term care settings be prepared. But I'd like to start by just providing an overview of long-term care for those who don't work in this setting. Long-term care homes are residential homes that provide ongoing care to residents whose needs cannot be met in the community. Okay. And a study has shown that over 50% of residents in long-term care are above the age of 85, and they present with diverse health condition, both physical and mental, and cognitive health, as you could see from the slides. And because of this, they are very susceptible to infections, okay? The first reason is that because of advanced age, because of other comorbidities, there's an increased use of invasive devices among residents in long-term care, and this increases the risk of infection. There's also the issue of malnutrition, which really has an impact on the immune function and also increases risks to infections. There's immunosenescence, which is decrease in immune response as we grow older. And this general diminished ability to complain of illness because of either cognitive deficits or other reasons. And like I mentioned, there are also comorbidities that predisposes residents in these settings to infection. So infection control within long-term care settings, it's really, really a priority so we can protect those living in these settings. But before we talk about how to prepare for the next pandemic, let's take a step back and understand what are some of the conditions that we need to fulfill for a successful outbreak management. So the first is early identification, either through diagnosis in order to implement prevention or control or treatment measures, the knowledge base and compliance of staff, residents, and visitors, effective communication, and the implementation of appropriate control measures, and of course, adequate human resources. So these are things that are required for an outbreak to be successfully controlled. And in the next slides, we're going to see whether, amongst other things, long-term care have this to be able to prevent or control an outbreak associated with a pandemic. So let's talk about the first situation, early identification. Okay. Long-term care homes rely solely on public health laboratories for infectious disease diagnosis. Early identification of a causative agent is important for appropriate treatment and control. But during the COVID-19 pandemic, we found that we were not getting results as early as possible. During the pandemic, sometimes it took up to 1 week for results to come back, at least in Ontario where I work. And this is not good because the earlier we have results, the better. And if I contrast this with acute care settings, usually in hospitals, you have laboratories within the hospital. So if you send a specimen, most likely the same day or the next day you get results. But for the case of long-term care, we don't have on-site laboratories. Therefore, specimens have to be sent to a public health laboratory, and they also have to deal with other specimens coming from the population. And because of this, results are often delayed. And delayed results mean delayed interventions. So one way to circumvent this is to ensure that public health laboratories prioritize testing of specimens from long-term care settings due to the vulnerability of this population. The next thing we need to control an outbreak is also the availability of treatment options. So a key strategy in the prevention of infectious disease, for example, is through vaccination. Okay. But during the COVID-19 pandemic, vaccine uptake amongst residents living in long-term care and even employees working in long-term care was very, very low. On these slides, I'm sharing two studies, one focusing on residents, the slide by the left, and the other one, the slide by the right, focusing on staff. And you can see that out of over 40,000 employees in this study, just 22,000, 56%, were fully vaccinated. So if we cannot get vaccinated, then we lose the opportunity to protect ourselves and therefore protect in order to protect residents. So even amongst residents, the vaccination rate, as you could see from on the slide by the left, was also about 40%. So vaccine uptake is an issue in long-term care. Okay, and as we know, for every pandemic, there are a few characteristics to define a pandemic. The first is a worldwide transmission of the infectious agent. The second is usually the infectious agent is a new or emerging pathogen where there is no usually vaccine or sometimes even therapeutics against, and population immunity is sometimes even zero or very low. And we rely on vaccination in order to prevent and control outbreaks. But in a sector where we are seeing gross vaccine hesitancy, then it raises question, how are we able to protect residents if in the event of a pandemic, staff and even the residents themselves are not willing to take a vaccine, as we saw from these two slides. So how do we fix this? The first thing is long-term care homes must start working on ways to promote vaccine uptake. During the course of the pandemic, I wrote an editorial in the Canadian Journal of Infection Control, a very interesting subject where the title was Public Health and Human Rights During a Pandemic, an unresolved dilemma concerning mandatory vaccination against COVID-19 for healthcare workers. So in this study, I was making an argument that governments have a duty to respect and to protect. Okay, so we have to respect human rights, people's choice to be vaccinated or not. At the same time, we have a duty to protect residents. So public authorities are cut up between this responsibility to respect and to protect. But overall, I think as a sector, we have to look at ways to continue to improve or promote vaccine uptake, because for us to be able to get through the next pandemic, we're going to have to increase our acceptance of vaccines, because that's the only way that a pandemic can come under control. When people are vaccinated, immunity is increased within the community, then the chain of infection is broken. So how can we address vaccine hesitancy? So we have to proactively create committees or champions for vaccine promotion before an epidemic or pandemic occurs. These champions can address critical reasons for hesitancy. Okay, one could be due to religious reasons, cultural reasons. Some people just have a phobia for injections, or some have medical contraindications. Others might just be myths about vaccination. So we have to start this conversation in order to increase uptake of vaccine in the event of a pandemic and once a vaccine becomes available. The next point I want to talk about is the knowledge base and compliance from staff, residents, and visitors. In long-term care settings, we have infection prevention and control leads. We have other employees, and usually infection control leads are responsible for the infection control program. But infection control is the responsibility of everyone, not just healthcare workers. Residents, patients, and visitors have a role to play in breaking the chain of infection. Therefore, pandemic preparedness education must not just be limited to healthcare workers, but should also be focused on essential caregivers who come to the home to look after their loved ones. They need to know how to protect themselves and protect their loved ones. Residents themselves need to understand basic infection control practices so they can protect themselves and protect others. So in general, IPAC or IPC literacy for the general population is essential. And here I'm not suggesting that everybody must be an expert in infection prevention and control, but the basics about infection prevention and control should be something that everyone who is associated with a long-term care setting should embrace. The staff who are working there, essential caregivers who come to care for their loved ones, and residents of themselves who live there, as well as visitors who come to the home. Basic concepts like hand hygiene, the proper use of PPE, how to identify symptoms, respiratory etiquette, and the subject of vaccine is also very important. The third is effective communication. Effective communication increases adherence to behaviors and strategies necessary to mitigate the spread of infectious diseases. Okay. And during the pandemic, it's really unfortunate that it's a time that also coincides with a lot of misinformation and disinformation. And I'm going to explain, in my opinion, what's the difference between misinformation and disinformation. So, misinformation is information that is inaccurate, false, but is spread innocently and without the intention to cause harm. Okay. Disinformation, on the other hand, is information that is fabricated by a person or group to deliberately confuse, manipulate, or cause harm to others. And there was no shortage of this during the COVID-19 pandemic. Some of us might be familiar with a lot of myths or misinformation, disinformation about the COVID-19 vaccine. Some said the COVID-19 vaccine were developed too quickly, therefore they are not safe. That was the only basis of their hesitancy. The vaccine was developed too quickly. By implication, they are not safe. Okay, but that doesn't mean that because a vaccine was developed quickly, it means it's not safe. It was just a new technology which was used to produce a vaccine at a more quicker rate. The second misinformation that we are probably all aware, the COVID-19 vaccine doesn't work. Vaccinated people are still catching COVID-19. So this is some of the facts that others use to spread disinformation and misinformation about the fact that some people were still getting sick despite being vaccinated. And there's nowhere in literature that suggests that when you get vaccinated, you don't get sick. Vaccines can either prevent an infection, prevent severe disease, or prevent death. And for the COVID-19 vaccine, we achieve a lot of these various ways that vaccines could keep someone safe. The next myth was COVID-19 vaccines can change your DNA. Some even said COVID-19 vaccines can cause cancer. COVID-19 vaccines can cause fertility problems and will affect your ability to have a baby. Some said COVID-19 vaccines contain microchips used to track you and can connect you to the internet or 5G networks. So these are all myths that were spread during the pandemic. And I don't think that this will be limited just to COVID-19. Even in the next pandemic, we should be prepared that there will be misinformation and disinformation. Therefore, we have to have a process in place to be able to counteract this information as they come up, and we have a space where people can get accurate and authentic information so that they are not caught up in the midst of this misinformation and disinformation that would ultimately affect their decision either to be vaccinated or not. So it's really very important that the IPAC community understands that the battle against the pandemic is not just fighting the virus, but also involve leading the communication, providing accurate information, and having a system in place to fight misinformation and disinformation within the general population, as well as specifically within long-term care settings. The next section, which I think is really the most troublesome to me, is challenges in implementing effective outbreak control measures in a long-term care settings. And the reason I put this slide here is just to give listeners a recap of the breaking the chain of infection. How do we break the chain of infection? You know, we have to understand that for an outbreak to occur, there has to be a pathogen, which is a causative agent, the reservoir, the portal of exit, how it leaves someone who is sick, the mode of transmission, whether it's airborne, it's droplets, or through contact, the portal of entry, how it gets to a susceptible host, and who is a susceptible host. So now, let's see if long-term care is truly prepared for the next pandemic. And in this case, I'm looking at a pandemic due to an infectious agent that is airborne. And for those who are listening and you're working in long-term care setting, I want you to ask yourself this question. If we were to have a pandemic that is caused by an airborne pathogen, can we prevent or can we control this infection in our settings? At least in my setting, I can tell you that no, we cannot. Long-term care homes need airborne infection isolation rooms for the control of infections that can or that are potentially airborne. And some of these infections, we know them already: TB, measles, varicella, and there might be other emerging pathogens that are airborne. But I can tell you that at least in Ontario, where I work, Ontario, Canada, I can't think of any long-term care home that has the ability to control an infection that is airborne. So in as much as long-term care settings are talking about pandemic preparedness, there's gross limitation in the ability to prevent or control a pathogen that is potentially airborne. Okay. One, because there is no negative, or there are no negative air pressure rooms or negative air pressure systems in our homes. The air change, air change per second within the homes is or per hour is not appropriate. We need air within the room to be replaced 6 to 12 times at least per hour to dilute any or remove any contaminant. Ventilation and filtration capacity is limited, as well as these settings also need pressure monitors. And this is not something that you see in an ideal or a typical long-term care home, at least at this time. So if we want to talk about pandemic preparedness, especially preventing a pandemic with a pathogen that is potentially airborne, then we have to start looking at redesigning of long-term care settings and taking into consideration that we might be challenged by an airborne pathogen within these settings in the future. Also, aerosol generating medical devices. Most residents in long-term care homes use aerosol generating medical devices. As we know, these devices increases aerosolization of microorganisms, thereby increasing the spread, and therefore highlighting the need for single occupancy rooms, which we'll see later. Not something that is very, very popular in most long-term care homes. So let's talk about room types, okay? For us to be really or truly be prepared for the next pandemic, we must discontinue shared rooms to single occupancy rooms. It's not rocket science. If there are 2, 3, or 4 residents in a room and one resident is sick, it's very likely that the others would be exposed as well. So the starting point is to switch completely from shared rooms to single occupancy rooms. Hand wash systems. And I just want to compare this with acute care settings. In acute care settings, hand wash facilities are readily available in patient care areas. Before a healthcare worker leaves a patient room, there's always a sink to wash hands. In the hallway, there are sinks. But in long-term care homes, hand wash facilities are not readily available in resident care areas. So one way to really improve on the management of infections that are transmitted by contact is through having hand wash facilities, sink in resident common areas, in resident rooms. This will improve hand hygiene by hand washing with soap and water, as we know, there are some infections or some pathogens that are, are not really susceptible to hand wash with alcohol-based hand rub, either because they are non-envelope viruses like norovirus, or they are bacteria like C. difficile that has spores that is a bit resistant to alcohol-based hand rub. So during this kind of outbreaks, and even with other emerging pathogens that we are likely unsure about at this time, might require hand washing with soap and water. And the installation of sinks in long-term care homes is something that is not very popular. Uh, One, because some argue that this is a home and we cannot have sinks everywhere in the home. But at the same time, even though it's a home, it is prone to really, really detrimental effects due to an outbreak or as a result of a pandemic. So we have to look at ways to improve hand hygiene, hand wash with soap and water by installation of hand hygiene sinks in resident care areas. The next problem is, how do we address the issue of isolation of or cohorting of residents during an outbreak? Okay. And the question is, can your long-term care home appropriately cohort sick residents during a pandemic? And I can tell you that for the most part, we don't have the possibility to effectively cohort within our long-term care homes. Usually homes are licensed a certain number of beds, say 150, 160, and usually all these beds are filled. So there's no vacant room, there's no vacant bed. And when there is an outbreak, it becomes very difficult for this individual who is sick, or for individuals who are sick, to be cohorted appropriately. In an ideal way, we need an outbreak area where you have exposed and well persons, you have exposed and ill persons, and you have confirmed positive cases. So all of these are actually cohorted appropriately from non-outbreak areas. But this is something that is not common in most long-term care settings, at least in Ontario that I work. So one way for us to be prepared indeed for the next pandemic is to ensure that this improvement in our long-term care facility building plan. And there's also the thoughts that we need to have cohorting areas where, in the event of an outbreak, in the event of a pandemic, we can appropriately cohort those who are sick. And again, as I wrap up this presentation, I want to talk about adequate human resources. During a pandemic, people are often scared. And long-term care setting is a setting that is already struggling with a lot of turnover of employees. And this is often worse during a pandemic because employees are looking at other options that have less risks, and they can work from home, and they will be less exposed to pathogens. So there's likely going to be a strain in the sector because of turnover. And presently in Ontario, for example, the government has increased direct care hours from 2 hours, 45 minutes up to 3 hours, and they're working towards having an optimum of 4 hours direct care. And this must be sustained during a pandemic, and there must be a system in place to ensure that during a pandemic, the sector can meet up with the human resource requirement, because the residents at this time, they need the caregivers, staff, and so on, who can be there to care for them, not at a time when they need care. And that's when we're seeing a lot of staffing issues in the sector that really will have a negative impact in the ability of the sector to be able to keep residents safe. So there has to be thoughts in terms of sustainability plan, of staffing, contingency staffing within long-term care settings in the event of an outbreak or in the event of a pandemic, so to say. Governments must make personal support worker role more attractive. And I know different jurisdictions have different designation for personal support worker. In the USA, it's called certified nursing assistant, home health aid. In other jurisdictions, personal care aid, direct support professional, whatever it's called in your jurisdiction or in your country. It's really very important that this role is made attractive so as to retain care staff before and during a pandemic, because the sector really relies on care staff to be able to meet up with the care that the residents so deserve. So I hope I've been able to touch on some of the key areas that I think, in my opinion, needs to be addressed as we prepared for the next pandemic. So with that, Paul, I'm going to hand it over to you, and I'm happy to take any questions.
Jim, thank you very much. Thanks for moving that next slide. It's okay. I'll put that on. I'll put that on that slide anyway. We'll just leave it there. Jim, thank you. That's the idea of cohorting. I know that came up during the COVID pandemic, and in truth, you're right. There simply was not space. There's such demand for long-term care rooms, and such a backlog, in fact, of people waiting for these rooms, that they just could not find, in many cases, could not find any room at all to cohort. I know one facility actually considered bringing in travel trailers and having people in these trailers. Is that ever going to be something that you think? I don't mean the trailers, but is there ever, do you think, going to be a mandate to make room in long-term care facilities, have one room set aside for something like that?
Yes, it's possible. And in Ontario, during the pandemic, towards the mid and end of the pandemic, the government, to the Ministry of Long-Term Care, had to mandate long-term care homes to reserve what they call pandemic beds. So what that meant was that if your home is licensed for 60 beds, you can only admit 57 residents or so, and you have 3 beds reserved as pandemic beds. So in the case or in the event of an outbreak, you can cohort those who are sick in those 3 rooms. But even with that, it wasn't effective, because sometime during an outbreak, you end up with about maybe 10, 20, 30, 40 residents who are sick, and you cannot even manage that in a couple of rooms. So that becomes a challenge. So, but I think it's very important for long-term care settings in terms of preparedness to change the way they design long-term care facilities. Existing facilities might not be able to meet this change, but new facilities, there must be new long-term care design guidelines to ensure that some of the things that I have mentioned on this presentation are actually taken care of or looked into in terms of the design and construction of new long-term care homes.
Well, exactly. One of the things that keeps coming up in Teleclass is when we talk about airborne infections is the idea of windows that can actually open and provide ventilation. Our speaker a couple of weeks ago spoke. He was talking about hospital transmitted tuberculosis. And he said if he could do one thing, or he was asked what one thing would be the most effective to prevent airborne transmission, he said windows that can open and just ventilation. Now, I know that throws off hospital and long-term care ventilation systems, the mechanical systems. Is that something you think might be in the cards in the future? Some way to bring air directly from outside into a room, whether it be an open window or something mechanical for individual rooms?
Yes, absolutely, Paul. Any engineering design that can increase the airflow and increase dilution of contaminants in the room, obviously is going to have a positive impact. That's something that's going to be helpful for sure. It's going to mitigate risks. But I think long-term care need to also look at typical airborne infection isolation rooms like we have in hospitals. Last month, in one of my homes, I was dealing with a case of tuberculosis. And you can imagine having tuberculosis in a long-term care setting where there is no negative air pressure room.
And very vulnerable people, yeah.
And very vulnerable people. So I think that, we have to, I know some argue that this is a home, but at the same time, the pandemic has shown us that though it's a home, the impact of an outbreak is even more than even a hospital. Therefore, we have to find a balance between the home-like environment and an environment that can protect residents. I feel very strongly that if we should have a pandemic that is due to an infectious agent that is airborne, we're going to be in real trouble in long-term care homes. And it's going to take a whole next generation facility design and new homes that meet this new design to be able to effectively have a system in place that can protect or control airborne infection. So far, it's not possible, at least in Ontario, Canada.
What about the use of portable air cleaning units? They were very big during COVID, where they would move them into a room that basically a HEPA filter, some had UV lights in them. Would implementation of those things on an ongoing basis, even when there's not an outbreak situation, do you think there's value in that?
Well, there is value in it. We have them now in all of our homes, and we deal with challenges now and then because some of them are noisy. Even the residents, they unplug them.
Yeah.
So they are not always on, and even when they are on, they have there's a limitation in terms of how much they can do. They are not per se, they don't create a negative airborne room. They simply increase the filtration of pathogens and within the room, which obviously reduces risks, but doesn't completely eliminate the risks, so to say.
Yeah, that's it. It doesn't create a negative pressure, which is something that you would want, of course, especially if with your TB outbreak, you'd like to have a negative pressure. The issue of vaccination. Talking to people who are resistant to vaccinations, talking to them about the logic and the science behind vaccinations in order to convince them, I've found to be absolutely useless, because there is such a mistrust of the science and of the government agencies who are disseminating that science. I think that's a whole, as you say, I think that's a generational thing that's it's going to move with the ages. Maybe in 20 or 30 or 40 years time, there might be more willingness to be vaccinated, but I don't see that happening in the short term, perhaps either of residents or of staff. Do you have any comment on that?
Yes, I do agree with you that there's mistrust, and part of the strategy to improve vaccine uptake is to build or rebuild that trust. And I mentioned in my slide, one of my slides, that it can start even at the home level, it can start at the community level, at a city level, or provincial or state level. We have to start building that trust. And for us to build that trust, we need to understand why are people hesitant to take vaccines in the first place. So it has to be a holistic approach to understanding vaccine hesitancy. Is it due to religious? Is it due to cultural? Is it due to medical reasons? Is it due to the trust issue, like you mentioned, Paul? So we really have to look at all of this in order to find ways to rebuild vaccine confidence. We see that even in long-term care settings nowadays. Pre-COVID, we used to have flu vaccination uptake of about 95% and above. Post-COVID, even those who usually took flu vaccines are no longer interested in flu vaccines. We're seeing a decline in flu uptake. So it really means that there's a loss of trust in vaccines as a whole. I think there has to be a lot of focus in rebuilding that confidence in the population.
Yes, that's a not a small task. I think that's something that can be assigned to somebody who has very broad shoulders. The one last thing that I wanted to discuss was one of the terrible things that has a very bad impact in long-term care, of course, are noroviruses and Clostridium difficile infections, that sort of thing. And those are so much to do with cleanliness and cleaning and disinfection. But in some of the photos you showed of rooms in your slides and of really all of our experiences, there's an awful lot of fabric in rooms. There's an awful lot of very comfortable chairs with fabric, uh, seats and arms and fabric everywhere. In fact, very many cases, there's rugs on the floor. How do you go about properly disinfecting a room when it's a home and when it's not an environment like a hospital where everything is fairly solid? How do you go about do it in your facility? Is that something that you
Yes, so that's a good observation. Uh, in our facility, we have transitioned to wipeable materials in common areas. So, for example, if you come to the lobby, the chairs that are there are made of materials that could be wiped. But in a residence room, and especially in a residence private room, they may choose to have uh, 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 fabrics that are made of, materials that cannot be wiped. And the risk is lower if this person is just living in a private room on their own, right? They are not living in a shared room. But in a shared room, for sure, we would strongly recommend materials that can be wipeable. And most homes are also discontinuing the use of carpets because they're difficult to clean, especially in the case of an outbreak due to norovirus where a patient might be vomiting and so on. So it's very important. I do agree with you. It's very important that the materials that we have in long-term care settings are materials that are cleanable. But again, as we said earlier, it's a home, and sometimes we struggle. Residents do have their rights and they have preference in terms of what they want in their room, and they might choose to have something that it's not IPAC friendly, and it's their choice. As long as they are living in a private room, we should be able to respect that as well. But in common areas, we should aim for materials that are wipeable. Paul, are you still there? Paul, I can no longer hear you.